Hello everyone, and welcome to this presentation where we will discuss two planned impact evaluations of mass oral cholera vaccination in Eastern Democratic Republic of the Congo. My name is Karin Gallandat from the London School of Hygiene and Tropical Medicine, and I will be presenting today with Anais Broban from Epicentre on behalf of larger teams involved in developing this research. We will begin with a brief introduction to the context and study sites, then describe our research objectives and the corresponding activities. We will be discussing two studies that have very similar structures with three core components, namely clinical surveillance, serological surveys, and follow-ups, including environmental sampling at the household level. We will end with a few words on expected results and challenges that we are facing. Cholera, as you know, remains a global health threat that disproportionately affects populations without adequate access to water, sanitation, and hygiene or WASH services. The Global Task Force on Cholera Control, or GTFCC, has defined a roadmap with the ambitious goal of cholera elimination by 2030. The multi-sectoral approach promoted by the GTFCC is based on three key components, including the targeted use of oral cholera vaccine, or OCV, in conjunction with long-term WASH improvements. The focus of this approach is on endemic areas with high incidence or transmission hotspots that bear most of the cholera burden. You can see here on the right that our study sites in Eastern DRC are located within cholera hotspots identified in this publication in 2018 by Lessler et al. Campaigns using oral cholera vaccine have been primarily targeting used as an outbreak response tool since the global stockpile was created in 2013. The safety and effectiveness of OCV have been consistently demonstrated over the past decades, with a recent meta-analysis estimating two-dose efficacy of 58% and effectiveness of 76% over 3 years. Those are the results that are shown here on the right. But all this is individual data, and while protection at the individual level is clear, with the exception of one study in South Sudan that is referenced here, there is limited evidence documenting the impacts at the population level, which include both direct and indirect effects after mass vaccination. This is due, on the one hand, to the limited number of mass campaigns that have been conducted in cholera endemic areas to date, and also to the weak clinical surveillance systems for cholera. So we need more evidence for the impacts of mass vaccination campaigns to help determine the role OCV could play in short-term reductions in cholera. So we are presenting today two studies intended to fill this gap. The first one will be taking place in Uvira, a town of approximately 280,000 inhabitants, where the London School of Hygiene and Tropical Medicine has been conducting research for several years in collaboration with local health authorities. We have been recording an average of 1,200 patients per year since 2009, with seasonal peaks about twice a year. The systematic use of rapid detection kits since 2016 suggests that approximately 40% of the patients presenting to the treatment center are confirmed cholera cases. And a mass OCV campaign was deployed last year following extreme flooding events in Uvira. And the OCV impact evaluation that we are conducting over the next 5-6 years is expanding upon existing research activities and will be jointly led by Johns Hopkins University and LSHTM. The second study in Goma by Epicentre will include two sites, one in Goma and another one in a rural place, which remains to be determined. The context of Goma is quite similar to the one in the first study, with an even bigger city located close to a lake in the region. And there is ongoing cholera surveillance with systematic confirmation of cholera by culture. A note here that the history of the city is marked by a very important epidemic in 1995, following the Rwandan genocide and population displacements. Cholera has been endemic in Goma for a long time, and more recently, a large epidemic occurred in the city in 2017. The health zones included in Goma were targeted during 2 successive OCV vaccinations in May and November 2019.
Okay. The objectives of our 2 studies are similar and working towards one direction. Our main objective is to assess the epidemiological impacts of mass oral cholera vaccination in endemic transmission hotspots, such as Uvira or Goma. We have identified several specific objectives to allow comprehensive assessment of the whole situation. First, we will seek to measure changes in confirmed cholera incidence and mortality over time within cholera treatment centers or units, as well as seroprevalence levels in the community. Second, we will investigate Vibrio cholerae carriage, shedding, and contamination in the household environment. Finally, our studies will provide an opportunity to characterize the genetic diversity and relatedness of Vibrio cholerae isolates circulating in the communities to better understand transmission dynamics and how mass vaccination may impact Vibrio cholerae strains. In order to achieve these objectives, 3 main types of activities are planned. First, clinical surveillance will take place for both studies within all participating cholera treatment facilities. Existing systems will be strengthened through the use of electronic or paper-based questionnaires in complement to the Ministry of Health patients registries. Where data will be collected electronically, tools are under development to allow online, almost real-time data visualization. Testing will also be performed at each study site by establishing capacity for culture-based methods in addition to rapid detection tests. Isolates will be characterized through antibiograms and molecular methods. We are in the process of optimizing a qPCR assay for the detection of toxigenic Vibrio cholerae 01. Molecular testing will be conducted at the INRB laboratory in Goma, and validation may also be performed at an international reference laboratory. The second activity will consist in representative serological surveys in the community. The figure here illustrates the principles behind serological surveys. It is estimated that among 100 individuals infected with cholera bacteria, only about 20% will develop symptoms. A quarter only of these symptomatic cases may seek care, and among those that seek care, not all will be identified and reported as cholera. As a result, a very small proportion of cholera cases is identified through clinical surveillance compared to the actual number of infection with Vibrio cholerae within the community. Therefore, serological surveys will allow us to estimate the actual incidence of infections in the community, independently from healthcare seeking behaviors. It will also help us better understand what proportion of cholera cases are captured through clinical surveillance, and this will be particularly important for modeling. For both our studies, sequences of several seroprevalence surveys are planned in the different sites. In each survey, serological analysis measuring multiple antibody responses will allow us to estimate new infections over the last 3, 6, or 12 months. We will thus be monitoring the level of immunity and vaccine coverage within the community over time and according to the different cholera seasons. We will seek to document any changes in WASH access or cholera response interventions, such as CATs that could influence our observations to take them into account in our analysis. Finally, the studies will both include household follow-up activities to better understand Vibrio cholerae circulation within the household environment. Stool samples will be collected from all the household's contacts of cases, and similar environmental sampling will take place in households enrolled in both studies. In Uvira, for each case household, a matched control where no cholera case has been reported will be identified nearby. We will seek to understand whether and how contamination of the household environment with Vibrio cholerae differs between cases and controls, and if we see any trends following over time following vaccination. One hypothesis is that vaccination will decrease the number of infected individuals, thus decrease shedding and contamination. In Goma, repeated visits with stools and environmental samplings will allow the study of cholera shedding and household contamination. We expect this household level component of our studies will allow us to better understand transmission patterns and help design targeted WASH interventions, in addition to documenting mass OCV impacts on transmission risks.
So we have just presented 2 ambitious protocols for the evaluation of epidemiological and environmental impacts following mass OCV campaigns in endemic cholera hotspots. We are obviously also facing some challenges. For example, starting these studies during the COVID pandemic has limited our ability to travel and spend time on site, and the documentation of effective OCV coverage has proven quite difficult so far. However, our hope is that these studies will provide critical insights into the coordinated use of OCV and WASH interventions. We feel that the diversity of approaches used should also help us gain a better understanding of transmission dynamics within hotspots. And lastly, these studies over 3 to 5 years provide opportunities to optimize research methods and to develop useful surveillance tools, such as the qPCR assay we're currently working on, or the dashboard that has been set up by the Johns Hopkins colleagues to allow almost real-time tracking of cholera cases. So we very much look forward to continuing the research. And we would like to acknowledge our funders, UKAID, Wellcome, and Gavi, as well as our partners. We are working with the National Cholera Elimination Program in DRC, Dr. Placide, as well as with local health authorities at each study site, the GTFCC and Oxfam. So thank you very much for listening. And we will be happy to take questions during the live EHF session or over email.